My name is Mel Wahlberg. I'm a registered nurse here at HCA Florida Healthcare. I'm proud to present and moderate our very first virtual Men's Health Summit. First up is going to be Dr. Marc Melser. Dr. Melser is a board-certified urologist that practices medicine here in Port Charlotte, Florida. We're happy to have you, Dr. Melser.
Well, I'm happy to be here, Mel. Thank you very much.
You're very welcome. It's an honor. So as a board-certified urologist, I think that you are an absolute expert to provide our community members and those outside of our community with some information about BPH. Yes.
Okay. BPH, what it is in essence are symptoms reflective of the enlarging prostate, slowing of the stream, waking up at night, an intermittent stream, the feeling that you don't empty. These are the troubling symptoms that will bring the man into the office.
So when do these symptoms begin to occur, and is it a part of the natural aging process, or is it something specific to individuals?
Well, there's always individuality, but it is an aging phenomenon. Hormonal changes occur that allow the prostate to grow. And over time, in each decade, the prostate grows in the aggregate. Now, there are some men who can be quite troubled by their urination as early as their early 50s, but generally this is something that occurs 60 years old and beyond.
Okay. How do you work up a patient that's dealing with a BPH?
It all starts with the basics of medicine, a good history.
Yeah.
And there are questionnaires that are formulated to answer the questions. One of them, it's a series of 7 questions that are asked of the patient. Emptying, slow stream, intermittency, we could go through them. And a good history. What's next?
Okay.
A physical exam. I mean, a digital exam. Boy, everybody's favorite, right? And so you got to feel the prostate. Now, you want to make sure there's no hard lumps on the prostate. That would be thinking of prostate cancer. But short of that, if it's just an enlarged, smooth prostate, you get an idea of the size of the prostate. You want to get a urine analysis. And is there infection? Is there blood in the urine? You want to check for that. And so those are the basics. But beyond that, then what do we do? Then we have something called a uroflow.
Okay.
Now, I have a uroflow in my office where a man urinates into a funnel, and we score how that flow is.
You do the history, you do the physical, and based on those factors, you come up with a clinical
judgment, and it's pretty hard not to start a man on medication. Mm-hmm. This is the introductory level treatment.
Okay.
And there are some men who will respond favorably to a drug like Flomax or Uroxetrol, which are called alpha blockers.
Are there any contraindications that people should be aware of, men should be aware of, to taking these kinds of medications?
There aren't too many adverse drug interactions with some of the, say, the cardiac or the antihypertensive medications.
You try the medications, you have your patient, I'm sure. How often, how long do we try out the medication? What's our...
Anywhere from 4 to 6 weeks is an adequate trial. The alpha blockers work very quickly. Men can find changes in the matter of the days. On the other hand, the 5-alpha reductase inhibitors, the dutastarides and finasterides, they take much longer. It could be as long as 3 to 6 months.
Trial goes great, you're on your medication, you're feeling better. That initial scoring that you do when a patient comes into your office has improved, so you keep on keeping on, right? But for those that don't have that response, where do we go next?
Well, right, then we talk about surgical intervention.
Okay.
We can, I just came back from the American Urological Association meeting. We talked about the new surgical interventions.
Some of the surgical interventions for the treatment of BPH are known to have both sexual dysfunction repercussions as well as urinary incontinence. And so,
Oh, yeah. And that's a big concern for many men. The BPH treatments, for those men who are potent, they still should be afterwards. But the sexual activity that you're really talking about is emission, is ejaculation.
okay.
After the gold standard transurethral resection of the prostate, the rate of retrograde ejaculation is usually quite high. I'd say two-thirds, if not higher. What has come along in the past several years is what you have here, and that is the aquablation of the prostate, the water jet aquablation. And I'm so happy, Mel, thank you, that we have this beautiful machine at Fawcett Hospital. We talked about flow, we talked about symptoms, and so you want to ask, what are the goals of therapy? What are the metrics? What are we looking for? We want to improve symptoms. So this will be accomplished with procedures that give a channel. And when you look at those metrics, it's every bit as good as the gold standard transurethral resection of the prostate.
You're using essentially a form of electrocautery, a monopolar or a bipolar, essentially to kind of remove that tissue, that benign tissue that's built up.
Right. So the analogy that I give patients is envision the prostate like a hard-boiled egg. And here we cooked this morning. So this is a hard-boiled egg. And in a TURP, we're removing the yolk only. And in all of the BPH treatments, this is it. We're treating the yolk only. The white we leave alone by design.
Now, utilizing the aquablation.
Yes.
What is the big difference?
The water jet is, what this is no heat, ultrasound guidance, the program is assisted with artificial intelligence. This is high tech. This is 21st century treatment for the prostate. And the water jet just ablates the tissue beautifully.
So you're looking at an overall reduction in your surgical time.
Absolutely.
Which is really important for a lot of different reasons, but then also this procedure using the aquablation, I'm significantly reducing my postoperative complications associated with the sexual dysfunction.
There's no doubt. In all the studies done by the Procept company, retrograde ejaculation, 10%.
Now, what about urinary incontinence?
0.
Wow.
Very impressive. I mean, you can spot those landmarks with ultrasound. There's not going to be incontinence with that.
That's
Big deal.
an amazing statement,
Yeah.
right? When you really think about it.
Well, the overall symptom profile improves. That's the drop in the IPSS score. For those men who are still potent, who still want to maintain sexual normalcy, this procedure will provide them that. I'm really happy that I'm involved with aquablation.
I am too.
Okay.
Well, Dr. Melser, it has been truly a pleasure talking with you today, and I'm excited for our community to be able to have this information. I'm so proud of HCA Florida Healthcare for supporting aquablation here at Fawcett Hospital.
I've been here for 31 years. I'm very thankful for HCA, Michael Erad, and we could go on and on with the names, but we want to be the BPH Center for Southwest Florida. I think we're on our way.
I think so too.
Thanks so much.
It's always a pleasure.
Okay, you're welcome.
Next up, I'd like to introduce Dr. Garrett Powell. Dr. Powell is a board-certified neurosurgeon practicing here in Charlotte County. Welcome, Dr. Powell. I'm really excited to be able to talk with you and to be able to present information to our community and to the greater population that hopefully this reaches. Talking today specifically about some neurological changes.
It's a great topic, and
Yeah.
and it's not discussed enough. And it's been in the news lately
It has.
for politics. And if we're all more aware of this, it's to our betterment and to the betterment of our family. So this is kind of my area of expertise. It's something I have personal interest in from family members. But beginning in our mid-40s and then continuing on for the rest of our life, we should learn to be cognizant about changes in our ability to think and execute our decisions. It's perfectly normal to have a slow decline in this, and that's the important thing. It's a slow decline. But
Okay.
what's interesting and what's helpful for people to know is the majority of cases of this aren't due to dementia per se, that is a degenerative change in our brain. It's due to depression. That's the single largest cause of cognitive decline in adults. And the first place to go is to your primary care physician.
So you've got those changes, say you're in your 40s and you're feeling like you're just not as sharp, maybe, right? So you go in, maybe we're going to do just basic lab panel.
Yeah, exactly. A basic workup. They're going to look for primary causes of this that could be related to physiology. For example, your thyroid or your pituitary axis or things like that, general health.
Okay.
Now we have some real simple inventories, little 2-page tests that you fill out that can really screen beautifully for depression.
Okay.
And so it's a pretty non-traumatic thing to do with your family physician.
I feel like depression still has a lot of negative connotations in our culture.
I agree.
It really is.
It still carries that connotation.
Yeah.
It's something that people think they can overcome on their own. And it's easier to overcome with the medications and the treatments that we currently have available. I mean, we really have some very good drugs available now. To me, the danger of depression isn't just the things you're losing out on in terms of the joy of life. That's important. What is bothersome to me is that people are missing years of their life that they could be enjoying things better. But what you can do in the meantime to prevent that, and this also helps with depression as well, exercise.
Yeah.
Believe it or not, it doesn't, at least to me, intuitively make sense that physical exercise improves brain function, but it does. It really does affect and improve how the brain execute tasks, memory, executive function, recall, all those things, and mood as well. So exercise is probably one of the first places to start.
So how much exercise are we talking? Because
Not a lot. 20 minutes, 3 times a week,
Okay.
at least 3 times a week. So that's not very much.
So when might you be concerned that we're talking about something else?
Great question. The person who has depression is bothered by those symptoms.
Right.
They're disruptive to their life. The person who has cognitive decline will minimize those things. Like, no, I'm not really forgetting things. And they become a little defensive about it. So if you notice that in a family member, and that's where, that's the beauty of having a spouse right there, is that our spouse can bring these things to our attention. And if it's a wife, they often will. The fact that they can bring it to your attention and then help guide you to see your primary care physician about that. Again, this is something that is easy to test for. The primary care physician will usually refer you on to a neurologist, not so much a neurosurgeon, but a neurologist.
Okay.
And screening for this has become
Correct.
completely non-invasive. You don't need contrast. You don't need an injection.
No
You don't
IV?
need- no IV. Just an MRI scan. Usually there's some physical testing too, checking our ability to walk, balance, draw a picture, solve mathematical puzzles, things like that. So pretty straightforward and pretty simple.
So what about some things that we can do, right? We talk about, Wordly and, the Sudoku.
Right.
Is that
Absolutely. The more you use your brain, it's like any muscle in your body, the stronger it will be.
Okay.
And that's something all of us have to be aware of. You need the challenge of doing something, taking up a hobby. In fact, I would encourage anyone who's in retirement now, find a hobby that you love and that you can be involved with.
Yeah.
The important thing is to engage with it, because that hobby, let's pretend it's bird watching or birding, just the fact that you're staying on task, you're paying attention to your surroundings, you're engaging with people as you go there, social interaction, all of those things are so key.
So if you see somebody that seems to be having these signs or symptoms, sometimes I think that people are apprehensive to approach them or to have that open conversation to say, do you want to talk about it? I'm concerned.
Yeah. I've had this in my own life with a close friend who I watched fall into depression, and I reached out to him so many times, and eventually he took his own life. And I look back with regrets on, could I have done more? Was there something else I could have done? But that's exactly what you have to do. You have to engage with them. You have to, without being confrontational in the sense of being aggressive, you have to tell them what you've seen.
And you branch on to the next kind of topic, Alzheimer's.
Yeah, Alzheimer's disease is a real issue. Alzheimer's disease is a very specific diagnosis. It's one that the neurologist will be the most likely to make for you. That's why referral to first your family doctor and then on to neurologist is important. But this is key. There are other treatable diseases that can mimic Alzheimer's, and that's why you start with your primary care physician. So we've talked about normal pressure hydrocephalus in the past.
Oh, yeah.
Yeah, and believe it or not, about 4% of people who are 80 and over have normal pressure hydrocephalus. It involves the cerebral spinal fluid in our brain. It's not removed from the brain like it should be. What the mechanism of that is, why is it not being removed, we don't know. But it's treatable with a shunt and a great return to quality of life. Billy Joel, as you know, just last week announced that he had been diagnosed with it. He'd been having these trouble walking and forgetfulness. Supposedly, Billy Joel has been treated with a shunt now, and he's talking about going back on tour when he recovers from the surgery. So, yeah.
It's amazing how much technology is out there that's advancing the way that we are able to diagnose and to treat our patients.
Oh, we are on the threshold of a new style of practice where in the past we treated disease, now we're restoring function. And that's what's amazing. I use stem cells sometimes for spine surgery to grow new bone, but they are doing studies, or they have done the studies, completed them with success, of placing stem cells into the brain after a stroke and restoring function in those damaged areas of the brain, in the spinal cord as well, for patients who've become paralyzed from trauma. So we are on the threshold of a new frontier in medicine, and it's great to see.
Doctor, thank you so much for being here with us today. And I think that it just is really important to emphasize to our viewers that if you're seeing these changes,
pay attention to them. Right. That's what I would say. If you're seeing these changes,
provider.
Yeah, and talk to your spouse or whoever the family member is.
Dr. Powell, thank you so much for being with us today.
It's good to be here, and thank you for inviting me.
Finally, we're going to be talking with Dr. Harsh Patel. Dr. Patel is a board-certified interventional cardiologist practicing here in Charlotte County. Welcome, Dr. Patel.
Thank you for having me.
Interventional cardiology is so incredibly important. Our cardiovascular health. I want us to kind of take a dive into, starting at about age 45, what are some of the bare bone basics that our viewing audience should start to be aware of?
In men, as they get older, past the age of 45, cardiovascular disease becomes one of the leading causes of morbidity and mortality. And that's true even today, even after many years of advances that we have made. And so, focusing on that and being aware of the signs and symptoms of things like coronary disease, it would be very important and just something that the general population should know about.
So, cardiovascular health, how much of it is related to your hereditary disposition versus your, environmental or lifestyle choices?
Genetics plays a big role. And some of this is not even fully understood. We're still discovering, and I think it'll be many years more that we'll still continue to discover all the genetic factors that play a role.
Yeah.
And we know that people that have a strong family history are certainly at higher risk. But that being said, environmental factors obviously play a big role. And some of the traditional risk factors are tobacco use, and high blood pressure, diabetes, elevated cholesterol, which is also tied into genetics, but it's one of the identifiable and treatable risk factors.
So a lot of the things that you just mentioned are screenings that typically are done annually when you go to see your primary care physician, correct?
Yes.
Some can be done even more so. For example, a lot of people have a blood pressure cuff at home. You can check your blood pressure at the grocery store.
Yes.
What is a normal blood pressure, and what is something that is cause for concern?
So technically, systolic blood pressure, and as we all know, blood pressure has two components, a top and bottom number, as I say to my patients. A systolic is the top number, which should be generally less than 120. That's the normal number,
Okay.
and less than 70 for the diastolic. Then there is the pre-hypertension range, which is a systolic blood pressure between 120 and 140, and a diastolic blood pressure between 70 and 90.
Okay.
That is still technically considered elevated blood pressure. But when we aim for blood pressure control in patients who have been diagnosed with high blood pressure, we can't always achieve, and we don't try to achieve a totally normal blood pressure because that can have some adverse side effects too. So a acceptable blood pressure for somebody who has high blood pressure that is on treatment would be a systolic less than 140, and a diastolic less than 90. Every family should have a blood pressure cuff, I feel. These days, battery-operated blood pressure cuffs are not very expensive, and keeping a diary of your blood pressure, if especially you've noted that it is elevated at Publix, and you want to measure it when you're sitting and relaxed for about 10 minutes, because just the act of walking into a place, especially if you're nervous, especially if you've climbed up some stairs, etc., will falsely elevate your blood pressure. So you want to be sitting and relaxed for 10 minutes, and then measure it and keep a log of it, and take that with you to your physician, and that really helps to determine the right course of action.
So talking about blood pressure medications, what's the current evolution or the current state of blood pressure medication?
Blood pressure has been one of the oldest problems
Yeah.
in medicine, and it is a problem that has no cure. And what people don't often realize is one of those diagnoses that requires, unfortunately for some people, multiple medications to
Yeah.
get under control. And it can change. The dosages that are required can change over time, depending on your circumstances. For example, if you had a blood pressure that was under control at one point, and then you gain or lose a lot of weight, then the requirements for your blood pressure meds can change.
But I want to kind of transition into another area of cardiovascular health, and talk about heart attacks.
Yeah, one of the leading cause of morbidity and mortality is heart attacks. And the word heart attack it should be understood. What it really means is injury to the heart muscle.
Right.
And the heart is a muscle. And the injury in most cases comes from loss of blood flow to the muscle. Every organ, including the heart, needs continuous blood flow. And a heart organ, especially like the heart that is constantly working, needs uninterrupted blood flow. And it's very sensitive to loss of blood flow. And it starts to get injured very fast when there's loss of blood flow. And the way that happens is, the arteries that feed the blood flow to the heart muscle, sort of the fuel lines of the heart, get clogged with fatty buildup. Building up of the fatty material is slow for most people over time, but the sudden event of a heart attack happens when a blockage that sometimes was mild, but most of the time is severe to start with, suddenly, ruptures, meaning that the layer of cells covering over that fatty buildup forms a crack in it, and now the fatty material is exposed to the blood, and the blood does not like to see or get exposed to that, and so forms a clot. That leads to heart attack.
What are some of the ways that we can screen ourselves, right? So
if we were wanting to just know your risk of having a cardiovascular event with a very simple test, we have a coronary calcium score, which involves not even an IV. You don't need an IV. It just, you get a quick scan of your chest, and it's looking specifically at your heart and looking at the calcium buildup in your heart. And it quantifies the amount of calcium. And the idea is that calcium is never normal in the heart arteries. It is always preceded by the fatty buildup, and in some people, the fatty buildup calcifies.
I'm not gonna lie, if I'm that guy that has this done and I hear from you that I've got a lot of calcium buildup, that stress feels like it might kind of weigh on me.
So if you were found to have an elevated calcium score, I would definitely get evaluated by a cardiologist. And the question then becomes, what kind of symptoms are you having? And your cardiologist may order a few tests to determine if there are other areas of concern. So one of those tests might involve a stress test. And if there are concerns based on that, then additionally other tests can be done, including up to heart catheterization to determine most accurately the percentage of narrowing that exists in your heart arteries. And depending on that, there are other options too. Or it may turn out that you don't have anything that needs any intervention right now, and that's all actually more often than not the case. Our goal is always to reduce the risk factors as much as we can.
So I want to talk about risk factors. We talk about a lot of them, right? So, obviously you want to try to quit smoking if you are. Not a lot of alcohol consumption, regular exercise, a good diet, fruits, vegetables. What about sleep?
Yeah, so sleep is one of those things that has a big impact on a lot of organ systems. And the association with sleep and proper sleep and heart disease is actually not understood or not recognized enough. One of the very common sleep problems is sleep apnea. And what's happening when you're having sleep apnea is you're essentially being choked. In a way, I just tell patients to understand it that way, because your airway is collapsing so that your oxygen is not getting to your lungs, and the amount of oxygen in your bloodstream is decreasing. And that makes your blood pressure difficult to control. And so there are many patients who have resistant high blood pressure, where they're put on 3-4 medications sometimes, and yet cannot be, their blood pressure cannot be brought under control. And many times we find that they have an issue like sleep apnea, which once that is controlled, their blood pressure control improves tremendously. The other direct impact of sleep apnea is that it increases your risk for heart rhythm problems. Including a very common abnormal heart rhythm called atrial fibrillation.
Why is atrial fibrillation associated with an increase for your stroke risk?
So first of all, what is a stroke? A stroke is essentially the same thing as a heart attack, but for the brain, where a part of the brain tissue is getting injured because an artery that supplies a part of that brain tissue is getting plugged up. And in this case, the link is that atrial fibrillation, which is a rhythm problem, causes a particular part of the heart to stop moving, which is generally otherwise always moving. It's contracting and relaxing with every heartbeat. But when it stops moving, when one is in atrial fibrillation, blood can go in there and just stagnate and just sit there. And that blood then starts to clot. And that clot can then break loose and go places anywhere in the whole body. And in fact, it's not just a stroke that it can cause. It can cause a heart attack if it goes to the heart. It can cause sudden loss of blood flow to a limb if it goes to a limb, or injure the kidneys in the same way as it can injure any organ. But we always worry about a stroke the most because it's the most sensitive organ in many ways. The brain is, and so that is the mechanism that links atrial fibrillation to having a stroke.
So, Dr. Patel, if there was one takeaway for the viewers that are watching this, one piece of advice that you could give that would have maybe the maximum benefit to have the happiest heart possible, what do you think it would be?
The single best thing that a patient can do if this applies to them would be to quit smoking. Because that is known to be directly linked with so much detriment to the cardiovascular system, but not just the cardiovascular system, risk of cancer, lung disease, etc. And just that one thing can really alter their life from a health standpoint in many ways. Yeah.
Dr. Patel, I always enjoy getting the opportunity to spend time with you and talking about cardiovascular health and interventional cardiology. There's so many advances in this area of medicine. So thank you so much for being with us today and for providing this outreach to our community and beyond.
Absolutely.
Really
it's been my pleasure.
it.
Thank you.
You're welcome. I'd like to sincerely thank you for joining us today. If you'd like to find out more information about any of the topics that we've talked about, or if you'd like to make an appointment with any of the physicians on our medical staff, you can do so by visiting hcafloridahealthcare.com. Thank you again for joining